Uh, Good morning, everyone. My name is Nikhil, and today me and my group member Joshua and Anieke are gonna present a case study in front of you all. So, we have a 20 months old boy, and he was admitted to the pediatric intensive care unit of this hospital because of the severe anemia. So, history of present illness. Informant in this patient is his aunt, and patient was well until 5 days before the admission. So on the first day, she noticed the boy started pulling his ear, and he did not have any fever or nasal congestion, rhinorrhea, or cough. So she took him to the ER, and he was diagnosed with the acute otitis media. So he was prescribed to take the oral antibiotics called amoxicillin, and from the day second to the day fourth, he had multiple episodes of non-bloody and non-bilious vomiting. And on the day of admission, he was in well and showing paleness with with abnormal rapid heartbeats and breathing. And if I talk about the past medical history here, he was born at a full term of pregnancy, which is after 36 weeks, and had been diagnosed with a abstinence syndrome. So this problem occurs when the newborn is exposed to the opioid drugs for a length of time while in the mother womb, and he was treated with morphine. And there is an absence of routine immunization in this case, so detailed vaccine is not available. Okay, so here we have a physical examination. So vital signs of this boy, we have temperature 36.8 degrees Celsius. Heart rate is 150 beat per minute, which is obviously high. Blood pressure is 84 per 59 mmHg, and respiratory rate is 44 breath per minute, which is high too. For the toddler, and oxygen saturation level is 100% on the ambient air. Here we have a systemic review. While doing examination, we found dark hyperpigmentation, what's called cafe macules on the skin, and a bright 1 centimeter red birthmark on the right buttock, which is a hemangioma. And while examining heart, on oscillation, we found abnormal rapid heartbeat and enlarged heart size. And along with that, we can also see uh, over here we can also see the enlarged heart size, and along with that we can also see the enlarged pulmonary vessels. So while examining lungs, we found the size of the lungs is larger than normal lungs, called hyperinflated lungs, and there is no evidence of pleural effusion. And while examining gastrointestinal system, we found enlarged spleen, uh, splenomegaly, and there is no evidence. There's no evidence of fecal occult blood test, and it was negative for this patient. Family and social history. So his both parents had substance use disorder, and father also had hyperpigmentation spots. You can see over here, and there is no travel history in this case. And they lives in urban areas, and he takes 0.6 liter of cow milk every day, which is deficient in iron, and it can lead to the iron deficiency anyway too. Okay.
Can you guys hear me?
Yep.
Yeah, so I'll be starting with the labs. So here we can see that the patient was diagnosed with sinus tachycardia and left ventricular hypertrophy. Here we see that in leads V4, V5, and V6, we see tall R waves, and we also see deep S waves in lead V2. So that, and they're both greater than 7 boxes, so we can diagnose left ventricular hypertrophy here. We're also seeing the rhythm strip here that he has sinus tachycardia, approximately about 150 beats per minute. Next slide. So in the X-ray, we can see and we see obvious cardiomegaly, uh, hyperinflated lungs, and mild pulmonary edema. Next slide. So the labs and investigation. We see that hemoglobin and hematocrit is low. That signifies anemia. The white cell count is high, probably maybe due to an infection. Platelet count is also high. The red cell count is low compared to the reference value. The mean corpuscular volume is 93.1. Compared to the reference value, it's greater, so we'll probably say it's macrocytic. The red cell distribution width is high, maybe probably due to hemolysis. LDH level is also high. Maybe that's because of the hemolysis. The uric acid is high too. Bilirubin levels are normal, and there's no jaundice. Next slide, please. So the diagnosis period, the chief complaint was severe anemia. Usually, there are three possible causes that would cause anemia. That's blood loss, hemolysis, that's increased red cell production, and decreased red cell production. Next slide. So now we are going to go through the three causes and to find out what is actually causing the patient's anemia. Firstly, is it due to blood loss? Usually in children, anemia resulting from blood loss is usually due to maybe birth trauma, or maybe a bleeding disorder, or possibly maybe a GI tract disorder, or if the patient is a teenager, maybe due to menses. But in this case, the anemia is not due to blood loss because no history of birth trauma was mentioned or a bleeding disorder was mentioned. Also, the GI2 test came out negative, so there are no signs of any GI disorder that may cause blood loss. So we can rule out blood loss as the cause of anemia. Secondly, is it due to increased red cell destruction? In cases like sickle cell anemia, G6PD, and thalassemias, where the abnormal red cells produced and there's now increased destruction of red blood cells by splenic macrophages, that is usually due to hemolysis. In this case, nothing like that was mentioned. There was no the patient didn't have sickle cell anemia. There was no sign, there was no history saying that he ingested maybe fava beans, or he had a Mediterranean descent. So we can rule out sickle cell anemia and also G6PD. Although the patient was treated for an ear infection and was put on antibiotics, and that would explain the high levels of LDH and splenomegaly, because it could cause drug-induced anemia. But the absence of jaundice, like no jaundice, and the normal bilirubin levels makes hemolysis unlikely. Next slide, please. So finally, is it due to decreased production? In the history, it was stated that the patient used to drink 0.6 liters of cow's milk daily, and he also had a high red cell distribution width and elevated PT count. This may suggest iron deficiency anemia because of the fact that cow's milk usually causes a minute, small amounts of blood loss and actually has less iron. So ingesting cow's milk for a long period of time might actually cause iron deficiency anemia. But usually iron deficiency anemia presents with microcytic red blood cells and not macrocytic. In this case, the patient had macrocytic blood cells, so we can rule out iron deficiency anemia. Another anemia we could assess is probably diamond blackthorn anemia. It happens in young patients as it's a congenital form of red cell aplasia, and it occurs in the first year of the patient's life. But usually this type of anemia presents with normal white cell count, normal platelet count, and some facial features like short stature and also like abnormalities in the face. But here, in this case, the patient had high white cell count and also high platelet count, so we can rule out blackthorn anemia. Finally, we could now consider that maybe it's due to a chronic illness that caused the decreased production of red blood cells in cases such as cancer. So, and in this case, there's elevated white cell count, there's elevated platelets, the prothrombin time is also elevated, uric acid and LDH levels are also elevated, which will lead to a possible diagnosis of cancer. But what kind of illness would cause this severe anemia? Next slide. Next slide, please. So yeah, the patient presented with multiple capillary malcos. He also had inguinal freckling. Those are spots, like hyperpigmented spots on the groin. and also an hemangioma on the right buttock. Or the father also had the same multiple markers, and this will lead to probable diagnosis of neurofibromatosis type 1. And neurofibromatosis type 1 is a autosomal genetic disorder that occurs caused by mutation in the NF1 gene. And usually this disease is associated with a rare form of leukemia known as juvenile myelomonocytic leukemia. This leukemia also has the high risk of progression into AML. So, considering our physical exams and considering the diagram that we see here, we could diagnose that this patient had neurofibromatosis 1, and his anemia was due to the leukemia that the disease is associated with. However, a blood smear would be done, a bone marrow blood smear should be done to establish the diagnosis of leukemia. Next slide, please. So here is just a first stage screenshot explaining, describing neurofibromatosis 1. You see it's autosomal dominant here, mutation in NF1 gene in chromosome 17. We see the physical features that it presents with, and most of these physical exams the patient presented with, so we could actually make a diagnosis of neurofibromatosis type 1. Next slide. So yeah, Kingsley will continue from here. Thank you.
Hi, can you hear me?
Yes, we can hear you.
All right, cool. So the pathological findings. So the bone marrow biopsy was done to narrow the differential diagnosis, which included infection, acute myeloid leukemia, chronic myeloid leukemia, myelodysplastic syndrome in conjunction with iron deficiency. And this bone marrow biopsy reviewed 100% cellularity. Reviewed numerous small hypolobated dysplastic megakaryocytes highlighted by an immunohistochemical stain for CD61, increased eosinophilic forms, increased myeloid blast, and reticular fibrosis. Next. So this, Nick, is it possible to enlarge it?
Sure, I can try.
You can see we have slide A, which uses mixtures of a right stain of the peripheral blood smear, which shows profound anemia, thrombocytosis, and occasional blast, which is signified by the arrows pointed at each of them. Slide B is a H&E stain of bone marrow, which shows the bone marrow is 100% cellular, increases eosinophilic forms, and numerous dysplastic megakaryocytes, which are seen in slide C and D. Nick, you sure? Slide C and D, which are signified also by the arrows there. For slide E, we make use of a right gasma stain of aspirate serum, which shows a blast, which is signified by the arrow, and the dysplastic megakaryocytes, which is signified by the arrowhead. For slide F, we make use of a reticular stain, which shows increased reticular fibers, consistent with reticular fibrosis. Slide G, we have an immunohistochemical stain for CD34, which shows increased myeloid blast. For slide H, we have an immunohistochemical stain for CD61, which confirms increased number of megakaryocytes and highlights their small sizes and hypolobated appearance, which I find is consistent with dysplastic morphologic abnormality. Nick, next. Yeah, so we have the cytogenic analysis. Analysis revealed monosomy 7 in 17 of 17 metaphases and no evidence of BCR ABL1 rearrangements, which are basically seen in acute myeloid leukemia. Mutations in EZH2, a splice donor mutation, which basically substitution of guanine by adenine, which can occur as a germline pathogenic mutation and can lead to neurofibromatosis. And it's seen also when in cases of mutation in EZH2 and monosomy 7, they all signify juvenile myelomonocytic leukemia. So taken together the morphology, clinical and genetic findings. Taken together, the morphology, clinical and genetic findings are consistent with diagnosis of juvenile myelomonocytic leukemia, a rare myelodysplastic myeloproliferative neoplasm in approximately 10% of cases occurs in children with neurofibromatosis type 1. Next. Treatment. Well, at this time, there's basically no exact cure except the allogenic stem cell transplantation. Until this can be done, treatment can only be arranged by standard care. Treatment is only the standard care, supportive management, and disease control. There is an estimated 50% survival rate after undergoing transplantation, in contrast to the use of intensive chemotherapy before transplantation in children with acute leukemia, although there is no role of intensive chemotherapy to eradicate juvenile myelomonocytic leukemia. In patients with NF1, bone marrow transplant is recommended. However, for patients with other molecular subtype, initial observation may be beneficial to determine whether the disease resolves spontaneously. Hypomethylating agents such as azacitidine can be used to predict results of targeted therapies. Next. Yeah, we have the references. Thank you. Any questions?
Wonderful. We have questions. 3 groups submitted questions. So group number 3 question coming from Hamza Khan. And guys, please kindly ask you to turn on your cameras while you will be answering questions. So I know for sure it's actually the real members of a group, not some kind of virtual friends. All right. So very good, guys. So what the first question is, why does cow milk causes iron deficient anemia?
So yeah, cow's milk is low in iron. It also causes a small amount of blood loss from the intestines. And as you lose blood, you also lose iron. So long-term ingestion of cow's milk could lead to iron deficiency anemia if you take it for a long time and
You're
you
saying
don't.
every time I drink milk, I bleed?
Well, I would say it's small. It's small, but it's not. Maybe it's not. It's not noticeable, but it's small amount of blood loss. And if you're not taking the appropriate diet, like maybe you're just eating leafy vegetables, then the deficiency could result usually long term.
I don't get it. So you're saying milk is toxic for enterocytes, causing necrosis, erosion of blood vessels, bleedings, or I'm just not getting how milk can cause a loss of red blood cells from our GI tract.
Well,
what is your kind of how you think about this?
it was stated in the article you presented, you gave us. So I think it's just basically cow's milk that causes gradual loss of blood loss, and the patient also was not eating nutrients. He was not taking appropriate food that would supplement for the minute blood loss.
Do you believe that milk causing blood loss?
Yes.
And through what mechanism? How you understand this? Let's say, why milk causing blood loss? Let's say how we can prevent loss of blood caused by milk. Let's say
by taking appropriate diets while supplementing, while taking milk. It makes it harder to absorb iron.
So it's probably what you're saying, it's not really blood loss, it's actually milk blocking absorption of iron.
Yes.
Oh, now I got it. Okay, because before I was thinking patient drink milk, but like say I have drink milk,
I mentioned
diarrhea because of the milk drinking. That's how I understand your answer.
Okay.
So before, so when I drink milk, so whatever iron I consume, let's say with other type of the food, it will be blocked by proteins of the milk, right? Absorption of the iron.
Yes.
Okay, then I get it. Okay, thank you. That's a good answer. Okay, so at least we figure out why cow milk causes iron deficient anemia, because it's blocking absorption of iron in the GI tract. Wonderful. Second question, Takumi, group 2, but probably he just transmitting question. But the question is like this. I'm reading exactly how it says here. What type of anemia we see hyperpigmentation spot sign?
I think, okay.
Cutan- Cutaneous hyperpigmentation, I think, are strongly associated with megablastic anemia, and even in the Fanconi anemia too, we see the hyperpigmentation spots.
So Fanconi anemia, and which one? Second one you mentioned?
I said the megablastic anemia, which is highly associated with cutaneous hyperpigmentations.
Megaloblastic anemia. So which kind of megaloblastic anemia is associated with hyperpigmentation? Because it could be B12, folic acid, megaloblastic anemias due to
It's,
liver disease. At
it's
least
vitamin B12.
so vitamin B12 deficiency causing pigmentation changes?
Yes.
And what mechanism is such? I'm just kind of not sure if you could explain, because I have not heard about this, that B12 deficiency causing pigmentation. That's why I'm kind of a little bit confused. What could be mechanism? Maybe I don't know something, and you guys know, can explain me. All right. No, if B12 you cannot explain, so what is, you mentioned two anemias, right? So megaloblastic anemia, and second one you said Fanconi anemia, right? So, what causing Fanconi anemia, guys? So I think in Fanconi anemia it could be hyperpigmentation spots. So
Fanconi, it is usually by the mutations in certain genes,
very good.
and I think which are FA genes, right?
Yeah, absolutely right. So it's mutations which are affecting myeloblasts, right? Erythroblasts, and cells not proliferating just. Very good, very good. All right, so group 2 also ask one more question. How was CD61 marker significant in the diagnosis?
So CD61 shows increased number of megakaryocytes and megakaryocytic cells and highlights small size and hypolobated appearances, which are seen in the juvenile myelomonocytic leukemia.
Wonderful. So that's related to megakaryocytes marker, right? And
Yes.
we have very high level of platelets in the patient, so which can kind of make sense now. All right, very good. Group number 5 asking question also, can neurofibromatosis 1 be found in adults?
Yes, it can be found in adults. As we see in this case, the father also had multiple Kafir lobe Malkus, and it's also an autosomal dominant disease. So yes, it can be found in adults.
Wonderful. And one more question is, how does antibiotics cause hemolysis?
Well, usually antibiotics could cause drug-induced anemia. The ingesting the drug could trigger the immune system to attack its own red blood cells, that will causing increased destruction of the red blood cells before the usual expiry date. So in long time cause hemolysis. That's how antibiotics can cause anemia.
All right. No, well, we will discuss this. And is it common that antibiotics causing hemolytic anemias? Maybe you can give examples of what antibiotics actually cause.
Usually cephalosporins, and in this case, to amoxicillin too was given, and it's also research that amoxicillin to cause hemolysis, but usually cephalosporins.
All right, all right. No, and one more question, and I think we're good to go. So why neurofibromatosis 1 and not McCune-Albright syndrome? What differentiates in this patient? Really challenging question, right, guys? So probably if you don't have any answer right now, it's not big deal. So, but what I'm asking you, your team submit me answer on this question, right, in the written form.
Okay.
All right. So, and I will evaluate your answer on this question.
Okay. Thank you.
All right. Wonderful.